Bom dia, não, boa tarde.
Good morning, everyone. It's a great pleasure to be here in another Biophoto Connect. Today, we have the great pleasure to have Professor Luis Gueiros here with us, a great friend, a super professor in oral medicine field. So, I would like to introduce Professor Luis Gueiros, an associate professor of oral medicine at Federal University of Pernambuco, where he also serves as coordinator the hospital dentistry service at the University Hospital. He is a recognized Brazilian researcher in oral medicine. His academic and clinical work focused on oral complications of cancer and cancer therapy, oral manifestations of autoimmune and immune-mediated disease, and management of medically compromised patients. He is actively involved in international initiatives, serving as a reviewer for National Cancer Institute, Physician Data Query, contributing to MASC guidelines through the Mucositis Study Group, and participating in the World Workshop on Oral Medicine as both reviewer and section head. He is also member of board of Brazilian Society of Oral Medicine and Oral Pathology, a frequent speaker, and he is one of our great friend and member of our INCT. So, Luis, thank you so much for being with us today. I know that you have a very busy schedule. Today you have the laser course going on. So thank you again for share your knowledge and for dedicate your time to our group. And the floor is yours. Thank you so much, my friend.
Well, thank you, Mando. It's a great pleasure to be here with you today, especially talking about this topic that we are about to submit as a part of the INCT project. So we are organizing a group of INCT faculty together with all the members, all the non-members actually, that we are organizing a big group to submit a project on Xerostomia and salivary gland dysfunction in Sjögren's and also radiation therapy. So we'll probably have very good news in the future. So it's a good starting point to present it today for you. So let me share my screen. Oops. Here. Can you see it?
Yes, we can see it. Perfect.
Okay. So sorry. So we're going to talk about photobiomodulation for Xerostomia in the management of Sjögren's disease. Oh, now I got it. Okay. So we need to define Sjögren's disease as a systemic autoimmune disease characterized by involvement of salivary glands and mostly salivary glands and lacrimal glands, but also involving several other exocrine glands and also other systems of the body. So we usually understand Sjögren's as a focal disease, but it's a systemic disease that may evolve with severe complications. And it is pathophysiology involves the lymphocytic infiltration of salivary gland tissue, and it leads to alterations and progressive functional loss. That's our main challenge to stop it. Up to now, we are not doing it so very well with drugs. So we are looking for another therapy that can help us to do it. it used to be classification as primary and secondary, but since the last classification system and then the definition of Sjögren's as a disease, not a syndrome, we understand that there is only primary Sjögren's, and it could be eventually associated with another disease, another autoimmune disease. So secondary disease is no longer an adequate term. It happened predominantly in female patients, as most of the autoimmune disease, and its prevalence ranges up to nearly 5%, maybe in some very specific population, but it's the second most common rheumatologic disease following rheumatoid arthritis. Zika syndrome is the hallmark presentation of this condition, and particularly dry mouth feeling is very intense, and is a very marked aspect of this condition. After dry eyes, the complaint is relevant, followed by profound fatigue and arthralgia. So even mild disease tend to present all these symptoms altogether. And we have a classification system. It's important to understand that it's not a diagnostic system, so it's used to get together patients with similar clinical profiles in order to perform a randomized clinical trial. But in clinical setting, this is not the best way to approach it. So sometimes even patients that do not fulfill this classification can be considered by a specialist as a patient who has the disease. Its activity is measured by this score, which was proposed by the EULAR, the European League Against Rheumatism, and it has 12 domains. One of them is the glandular domain. So the glandular, for the activity, is not related to dry mouth, but it's related to lymphocytic infiltration. So swelling of the salivary glands, which is related to a lymphoma risk. It is also understood as a part of the classification, a part of the activity index. Systemic involvement, apart from salivary gland to exocrine glands, happened up to 40%. Sometimes some studies report up to 50% of the patients, and it may present the involvement of the other domains. So neurological, we have central and peripheral neurological involvement, also in the other, as you can see. So sometimes patients start with paralysis or neuropathy, and the main reason will be diagnosed as Sjögren's in a following time. The primary manifestation is also those related to salivary glands and lacrimal glands. So usually the oral involvement happened to change the oral microbiome. It leads to mucosal changes, atrophic mucosa, fissured tongues, and also secondary complications of this dry mouth, including mostly denocaries, periodontitis, oral ulceration, secondary to trauma, because we increase the likelihood of trauma when we lack saliva, and also stomatitis. By this mean oral candidiasis usually. The mechanism of salivary gland dysfunction is as I said, the lymphocytic infiltration of TCD4 cells and also B cells, and it leads to asthma cell apoptosis, and it modifies the salivary gland and ultimately promoting progressive fibrosis, which replaces the functional gland with cut tissue. So when it happens, it's really it's a challenge to have an adequate management of the symptom, because the gland is no longer able to produce saliva. The functional consequences of course is reduce the quantity, and the quality is also altered. So we have a real challenge regarding the caries, which is a major challenge for these patients, but also for quality of life. And we need to have a clear distinction with reversible damage and irreversible damage. Usually, geography is classified as irreversible damage since each damage that the patient have will not be reversed. Sometimes, if we can access this patient in an early phase, we can stop the structural progression. But reversible damage, probably the best example is medication-induced hypersalivation, which is, by the way, the same condition the condition that responds better to PBM as an alternative treatment. So we need to understand this distinction. The current management of dry mouth includes not only for drugs, but it can be used for other similar condition that happens with dry mouth. So we need to educate our patients, and most of the times we fail in doing that. But avoidance of tobacco, alcohol, caffeine, and further desiccation. Sometimes we do it. We say in the first consultation, but we didn't keep informing and reinforcing this. It's really important. Of course, salivary substitutes. We have now several options in our local market because we didn't have it a few years ago. So it's interesting to have them available to patients, and it helps a lot. But it has a limited action. Mechanical stimulation, so usually sugar-free gums and also some other conditions that some other stuff that can help to stimulate, but usually chewing is the best way of stimulating salivary gland production. So gums, sugar-free gums seems to be a good option. And also hydration is basic. Patients should have a more frequent water intake in order to maintain at least the best oral moisture possible. We have topical agents, so omega-3 supplementation, topical cyclosporine. They're mostly used for dry eyes. We have other topical treatments, but they're used for dry eyes. We sometimes use like topical pilocarpine, but it's off-label and we don't have it clearly described. So we go to the pharmacological agents, and the most common is the pilocarpine and cevimeline. They are very good in stimulating saliva, but they are also very good in promoting adverse events. So sometimes up to 30% of the patients on the pilocarpine, regardless of the baseline condition, they do not bear to continue the treatment due to adverse events, mostly profound swelling and gastric irritation and colics and cramps and so on. So when we need advanced therapies and so-called rescue therapy, electrostimulation, we have some electric devices, but there's one particularly called Salipen that seems to have a better action for advanced cases, and also biologic therapy. These treatments are expensive and they are for now not indicated only for dry mouth. They're indicated for all the systemic symptoms, and some of them may have also an impact on salivary gland, but we can't rely on them because, as far as you know, those they are actually on market. They do not show a really interesting result regarding specifically to salivary gland function. We do have like new drugs that are on the way to be approved that maybe they can improve, but of course they'll be indicated for not for dry mouth but for the systemic complications, and they may have also an impact on dry mouth. So we have an unmet clinical need because our treatment is mostly palliative. We have the pharmacological challenges that I told you about. Advanced disease, we lack an adequate efficacy on that, and also it impacts negatively on quality of life. And we need the rationale for alternatives is ideally non-invasive. It should stimulate the salivary gland and leading to a better salivary gland production. And also it can be it can have an adjunctive role. So maybe we can add a new intervention together with the other interventions that we already have in order to have a better patient compliance and also a result. That's our challenge. And in my impression that PBM can help in this condition, in this sense. So the physical simulation approaches we have is not only for Sjögren's, but for all kinds of dry mouth related to several other conditions. The TENS can be used, acupuncture can be used, and PBM can also be used. Acupuncture was also included as an alternative for treating or mitigating at least Xerostomia and hyposalivation in cancer patients. So we have a stronger evidence on the subset of patients, and some more recent studies we also showed conducted in USP Ribeirão. It showed also a good result using acupuncture to salivary gland disease in Sjögren's disease. This scoping review showed an interesting evidence that these interventions may help to improve salivary gland function, but it shows different efficacy according to the cause. So Sjögren's disease seems to be the most difficult condition to deal with. Our clinical findings, these clinical findings show most favorable outcomes in medication-induced hyposalivation. Of course, the salivary gland is protected, is functional, but it is inhibited by the medication. So we can stimulate, and it should function properly. But the poorest response was observed in Sjögren's disease patients. So that's our challenge. Of course, why do we can use PBM? What's the rationale for that? It's non-invasive. It has a strong theoretical basis that we also know the cellular. Oops, sorry. Let me get back. Let me turn it off. Sorry. It has an established efficacy. Just a second.
Luis, if it's important, you can take the
I don't
call.
know. Maybe.
No problem. You can mute your microphone here, and we wait for you. No problem at all.
Maybe let me try to do it because my cell phone is off.
Your kids. I know that you have the kids.
Yeah, maybe something like related to them. Let me turn my WhatsApp off. Let me see. So it has a very good safety profile as well, and it is cost effective in several conditions, mostly oncologic conditions. They showed a very interesting cost effectiveness, but it should be demonstrated in other settings. So our clinical question, the most important clinical question is, can PBM effectively stimulate in Sjögren's disease? And also another question is, can it prevent the disease progression on salivary glands? It can be also more difficult, but we can also try to answer that. We have a well-established algorithm for Xerostomia management in Sjögren's disease patients. It was proposed by Yolar It is start with assessing the salivary gland function by measuring unstimulated
I think that
gland
the
flow.
signal,
And if it was find hypersalivation, sorry,
I think that the signal, your signal, is not so good.
can you hear me?
Yes, but sometimes it's freezing a little bit. For me, it's happening this. I don't know if the other guys.
Let me,
For me too.
okay, let me try to change it. Well, it is. So let's see. Is it okay now?
Much better. Thank you.
Okay. Here. So we first of all, we need to measure the unstimulated salivary gland flow. And when it's below 0.1 ml per minute, we should also perform the stimulated salivary gland flow. In cases we have like a higher unstimulated flow, we don't need to perform the stimulated, but when it's too low, we should do it. Well, the idea is to define whether the gland respond to stimulus. So if we have a stimulated salivary gland flow higher than 0.7, it is normal or mild dysfunction. 0.1 to 0.7 is moderate dysfunction, and below 0.1 is a severe dysfunction. So in how we deal with that, mild dysfunction, the first line is non-pharmacological, so PBN can be an option. Also for moderate dysfunction, non-pharmacological. If no response, then pharmacological, the same for moderate. But they also, for moderate dysfunction, they propose rescue therapy as mucolytic and also electrostimulation. For severe dysfunction, we don't rely on stimulation anymore. Probably the gland won't respond. So it's mostly saliva substitutes and also supportive therapies. This is a case series that evaluated medication-induced hypersalivation. So it's a short case series, but they proposed a laser protocol, 10 weekly sessions, 22 points per section, and they observe a significant increase in unstimulated salivary flow, and also it keeps up, it was increasing until the last session, and staying up to 45 days, which was when they stopped the study. So it was sustained until this time. And patient also, it also improved the quality of life, and it seemed to be an interesting approach. Non-Sjögren's patient, they have excluded Sjögren's and also head and neck cancer patients. This scoping revealed they show 24 evaluated, 24 studied, and they have concluded that medication-induced salivary gland dysfunction has the most favorable outcomes, followed by radiation-induced, and then we have Sjögren's disease. So radiation-induced varies according to the area of the field of radiation, the volume of salivary gland involved in the radiation field. So of course it can promote a better response in when we can spare the salivary gland. So and it does not happen in Sjögren's disease. So that's why we have a poor response, and it is also a progressive response. progressive condition. This randomized clinical trials was performed in in a mixed population, and it also reported a similar result as the scoping revealed. So significant improvement in drainage test, significant improvement in oral quality of life. Some benefits persisted up to 1 year follow-up, but the population was highly heterogeneous, so it showed better results for some specific population and limited results in other populations, but they were evaluated altogether. So they couldn't conclude on that, but it seems to be similar to the previous study. When we go to Sjögren's disease, this study was performed by the group of Unifesp, and they have involved 66 patients, 33 in each branch, active and sham laser, and 12 sessions over 6 weeks. And they have used the old definition, like the 202 AECG criteria, but it doesn't change that much since they were using the so-called primary Sjögren's. And this outcome included Xerostomia inventory, but also the salivary flow rates. They lack, and they found no response regarding to salivary gland function, so no improvement in xerostomia and salivary gland flow, and also in biomarkers. So they concluded that using PBM or LLT, as they call, was ineffective in an established primary Sjögren's syndrome. They also suggest that maybe if they have evaluated early disease, they may have a better result, but it was not performed, and no, they didn't perform another study after that. This is a study that our group has published recently, and we have evaluated 50 Sjögren's patients. Our initial idea was 60, but due to time constraints, we need to close the study. So that's why we have a different 22 inactive, 28 in sham. But the population was confirmed by the most recent criteria. And our outcome, the primary one, was the xerostomia. I'm going to talk a little bit more about the outcomes. And what we understood that in week 8, we have a marginal benefit, and regarding the patient perception as VAS scale, and also the resting salivary flow rate. But we had no significance on week 12, so it seems it was a small group. It may help in a sense that we have the impression that we can replicate this protocol in a larger sample. So we have used it. We have tried 2 different protocols of acupuncture as a pilot study in order to select the best one. And when we did it, we applied it to the patients. And so that's, as I told you earlier, we have some evidence. We have strong evidence on acupuncture, and we have some evidence that laser can act as an acupuncture stimulus using in acupoints. So that's what we did. And the primary outcome, we have selected more strict outcomes. The primary one was not increased, but particularly 14 millimeters in VAS scales at week 8, 14 millimeters. It was relevance for dry mouth. So included this as the primary outcome. Inventory improvement seems to be relevant, and also difference in esprit, which is also proposed by the OLA group as a subjective symptom evaluation, difference greater than 1. So we have more strict outcomes. Probably that's why we didn't have any statistically relevant finding, but we are excited to perform it in a larger group, and that's the idea. We are going to apply this protocol to do it in a larger group. A group will use acupuncture, the other group will use just salivary gland points, and of course we have the controls, and we're excited to see if what happened in a larger group. We have some limitations and also some strength. We do have few placebo-controlled studies, which has demonstrated a high safety profile that we know it from other study in other conditions. We have a strong theoretical foundation, and the proof of concept was already established. So we are good now to go for a larger study. Of course, we do have sample size constraints. The protocols vary a lot. The evidence for specifically to Sjögren's disease is not strong at this time, and also we have mechanistic gaps. And this can be, as we understand that this can be at least mitigated by a multi-center study. But why these patients particularly respond differently than other patients with dry mouth? Because first of all, the medication induced is reversible. Sjögren's disease is irreversible and progressive. Patient keep going on autoimmune infiltration, leading progressive fibrosis, and ultimately with loss of regenerative capacity. So it is our challenge to deal with that. We have also some methodological issues that we can resolve under the INCT. It's a very good strategy to deal with that, to protocol heterogeneity, to sample heterogeneity, to find a good outcome variability. Also, at the same time that this INCT is happening, we'll have up to see in the near future regarding to dry mouth. So the outcomes suggested by them to deal with Xerostomia and salivary gland hyperfunction. And also design challenges and blinding, and also in the conditions related to the study itself can be adequately managed under a multi-center protocol. We have some unanswered questions on this aspect. The wavelength, of course, we'll use a near infrared, but some studies have used another wavelength. A well-established dosimetry, frequency and duration, so how long and how frequent we use the treatment. What's the best application strategy? So extraoral, transoral, intraoral, sorry, transdermal or intraoral. It's something that we should also evaluate, and the timing of intervention. So it is really difficult to us to identify patients as early stage disease. We tried, but among all those 50 patients that were included in the study, not a single one of them had early stage disease. So it will be much harder to find them. But we can also try to adapt and understand it properly under a more strong randomized clinical trial. Our future directions will be maybe understand combining mechanistic and imaging studies, so we can perform salivary gland imaging, specifically ultrasound, to see whether what happens after laser or during laser. It can be interesting to see what does laser promote in the salivary glands. Also, some biomarker profiling to see the long-term response. How long does what does the immediate change in transcriptomics and cytokines, and how long does it keeps. The stratified multi-center randomized clinical trials, that's the idea of having standardized protocol and phenotypic phenotype stratification, so the same profile of patients, and also maybe evaluating it together with systemic medications and with also pharmacological therapy may be the ideal approach, because it's a complex and multifactorial disease with a complex pathology and pathophysiology. So maybe adding therapies may be the best option to deal with these patients. We'll try to identify early disease. My impression that it will be really hard to do it, but we will try. We'll document residual function, either the resting salivary flow and the simulated salivary flow, and also pharmacologic intolerance. It can be a good option to selection. So those with uncontrolled asthma, narrow gland glaucoma, which are formal contraindication for pilocarpine, they can go on the laser. And also define some good implementation strategies. As an adjunctive role, it can be maybe a good option, not as a monotherapy. Also, we have strong informed consent and expectation management, because it is probably one of the most strong responsible for bias in laser research, with lack of expectation management. We should have it properly done. So our takeaway message is fundamental distinction of Sjögren's and other conditions. It is a reversible autoimmune glandular distress. It is we have limited results in the management of salivary gland hyperfunction in this condition, not only regarding to laser, but also to other therapies. Current clinical status of PBM in this setting is experimental. We are far away from a clinical endpoint, a clinical use by now. First of all, we need to define whether it is the efficacy and then the applicability, because how can we manage a chronic disease with a therapy that the patient needs to go to see a professional frequently? So it is something that we need to understand it more properly in order to define it. And also some advancements is the application to mechanistically driven research in order to probably incorporate imaging and post-treatment biomarkers, and they'll help us a lot to understand how it should go in the next phase. This is some of more relevant references, and I'd like to thank you, and I'm good for questions if you have.
Luis, amazing lecture. Complete lecture, very good. Thank you so much. Let's open for questions to our audience. Any questions, my friends? I think that you brought the most important. You cover everything, especially because we do not have so many studies, and the studies that you already have, they have this mixed population thing. They also have, when we are talking about specifically Sjögren disease, we don't have so many patients, and we have patients in more advanced stage, I think, in the same way that you present to us. And the other point is that if we cannot reverse the damage, because since we have the disease installed and the acinar cells passed, we cannot accelerate or we cannot heal this tissue. We can only stimulate the remaining acinar cells to produce a little bit better or a better quality. So for me, it's the the worst scenario that we have when we talk about xerostomia patients. But we need to do research and conduct clinical trials in a multi-center design will be great.
It'll,
So we are really expecting to conduct in INCT because it's the way that we really can develop this kind of study. So are you planning to present only acupuncture or also acupuncture plus the biostimulation in the salivary glands per se?
Actually, so far we have planned to do like one branch will be acupuncture, the other branch will be salivary
Okay.
gland. We didn't plan to do a group mixing them, but
Okay.
it can be an idea. We don't know yet whether probably with the Gemini Evo, we can perform extraoral. It can be a great approach to stimulate the salivary glands. And so we can compare them with the acupuncture, and also eventually can also mix them together since we have access to a great number of patients. We can do. By
Could
now
you
we have like Recife, Belo Horizonte, Ribeirão, Manaus, e Bauru. So 5 centers collaborating in this Sjögren study, and some other will collaborate in the radiation therapy study.
Perfect. Also, you can count on us
They
here.
will take us up to 1,000 Sjögren's patients. We have access to nearly 1,000 Sjögren's patients, so it will be interesting because we can have access to a large number of patients, so we can perform a very strong clinical trial.
And are you planning of course, classify these patients, thinking about to analyze them in separate way according to the development of the disease, the progression of the disease, the stage of the disease? Are you planning to separate them?
Yeah, we'll try to do it mostly based on that EULAR classification, so of residual function, defined by if we have like some patients that have more than 0.1 in the resting salivary flow, it will be a group definitely. We'll stratify the stimulated salivary gland function in order to have it to have a more adequate idea of the capacity of laser stimulation. Another point that we don't know yet, and maybe we don't have time to do it in this moment, but we can start, is whether laser is capable of stopping the salivary gland dysfunction. So if we start it now, are we able to stop this improvement? So the lack of function, the progression, yes. So it's something that we can also evaluate.
We can see this in oral mucositis. We can maintain the cells alive. So maybe depending on the stage of the patients, maybe we can maintain the cell alive and reduce intrasalivary gland tissue the inflammatory process, because the PBM we can work in cells, maintain the cells alive, but we also could reduce the inflammatory process. This is the biological idea of the PBM. So probably using the PBM with the right protocols that we don't know what is the right protocol. We have the possibility of modulate the inflammatory process.
Yeah.
So maybe we can reduce the damage in the acinar cells and also in parallel stimulate these remaining salivary acinar cells.
Yeah, that would be like the ideal world. So
Yeah.
if we we have this result, which would be really interesting to see, because up to now, it's expensive and it's frustrating because the patients rely mostly on supportive care.
And do you have any results from quality of life analysis combined with photobiomodulation? Because sometimes what we can see is that we do not have a lot of increase in the salivary flow, but in other situations we can see the patients reporting that
Yeah,
even
I,
if they
I got
don't
you.
increase the salivary flow, they have a better sensation because we can modify the quality of the saliva.
Yeah, it was not performed in Sjögren's, it was performed in some trials. Those trial was organized by Erica. I'm quite sure that they have Erica Natal. I'm quite sure that they have evaluated it, but in medication induced xerostomia, and they seem to have this result. So yes, we didn't. In our group, we have checked this the quality of life, the xerostomia related quality of life, but we didn't found any relevant aspect. But it seemed to happen in other patient groups.
I think that will be amazing, the future studies that you are designing, because we have this opportunity to combine a large number of patients, different centers, and we can also analyze oxidative stress, other molecules, quality of life. So it will be amazing. And this is something that we really need to invest thinking about
Yeah, well,
IN.
that's interesting because we are thinking about that, but some of probably the worst patients, they lack saliva at all. So we can't have not even a drop to in order to perform any analysis. So we will rely on the blood, which is not the best option. But for most of them, we can get at least a little bit of saliva, which is enough to perform the analysis.
And Luis, do you think that we should try an approach with the rheumatologist, for example, trying to offer, thinking about our public hospitals, offer to patients with arthritis, with like a preventive approach in salivary glands?
Well, we don't know yet. Some of these patients doesn't have any properly Sjögren's, so they have Zika
Mm-hmm.
as arthritis, but it's not the real
Sure.
deal, the real Sjögren's disease. And so probably it seems to work, at least theoretically, they seem to work better in these patients than in the Sjögren's patients. So yes, we can, especially, I'm not sure if preventively, because we don't know who will develop it. So we'll treat
Okay.
everybody to reduce, to have just a fraction of the patients to have a beneficial effect. But my impression is that at least those who are starting to have dry mouth complaints, we could take a earlier look at them, regardless of Sjögren's. So we have lupus and dry mouth, arthritis and dry mouth. These patients, well, first of all, we need to check whether they have Sjögren's or not. And even in case they don't have Sjögren's, it's a different study that we can also
Yes,
check this.
of course, a difference. But I was thinking about it's really hard to have the patients in an early moment of the disease. It's really hard. So I don't know
Yeah,
how
because
to.
we don't know whether these patients with another conditions and not Sjögren's, if they do have like progressive salivary gland destruction. So maybe they don't. So it is related to some other aspects of cytokine inflammation and other aspects that can be reversible. So maybe these patients, regardless of maybe those on systemic sclerosis because they don't have drugs, but they have sclerosis of the gland, so it's difficult as well. But the other autoimmune disease, maybe they can have a benefit on that.
Let me ask you a question as a clinician. Do you offer PBM for your patients in some moment in your daily routine? Because we don't have the support from the literature to for all the patients. If you offer when, and if
You
you
mean
don't offer, why?
you mean by dry mouth management?
No,
No, I
just for
don't.
okay, for Sjögren disease.
But for Sjögren's, no, I don't. I don't think we have like strong evidence to put them on a routine treatment that may not be beneficial. So whether we are dealing with a public setting patient or private setting patient, they have costs associated with the treatment, and I'm not comfortable to offer it to the patients.
Thank you so much. Thank you so much. Guys, any questions? Fer, any question?
Thanks for your presentation. We work with a lot of patients with Sjögren's disease. And could you tell us which PBM protocol do you suggest to apply if you had to apply in a patient with the disease, with this disease?
We have using, well, let me check. I don't remember by heart. We have used, if I'm not wrong, 3 joules per point. Actually, for eyes, it was 3 joules per point in some of the points and 1 joule per point in one specific point, because it was suggested by our acupuncture expert, which is a dentist and specialist in neurofacial pain, and she advised us on acupuncture. So by some, I can explain to you because it was like some theoretical aspects related to acupuncture. She advised us to perform higher energy in some points and a lower energy in some others.
Sure.
Any other questions? No? Luis, thank you so much. It was a brilliant lecture, and we have so many things to study, to discuss, to collaborate. And for us, it's an honor to have you, your team here with us in INCT. And I hope that we have great moments ahead, sharing knowledge, having fun, and also using the photobiomodulation or the photonics in the right way.
Yeah, thank you. We are really excited. And I mean, myself, Paulo, Tarcilia, we have talked about it. Also, I've talked by message with Carol from Ribeirão and Tati from Manaus, but they are also excited, enjoying this project. But I have met with Paulo and Tarcilia, and they are really keen to start it because it is a challenge that we need to overcome. And doing that, the INCT is probably the best way to get us all together, because we know each other, we respect each other, we admire each other, but for life is happening, and we never talk about it doing something together. So that's what the best. It's happened not only with us but everybody. So I believe everybody's really happy to work under this project, because it's amalgamating a great good things into science, and it's really interesting.
So thank you guys. Have a great Friday, and we see you in 15 days.
Mas vou mandar bilhetinho ali.
Okay, we can stay. Yes. Thank you guys. Bye bye.
Bye bye.
Bye. Thank you.
Gurias,
Oi,
tudo bom?
Acho que só para
tudo.
de gravar.
É?